Good afternoon, everybody. Are you still awake? Yes? Good. Thanks for staying on. I see some people might have left, so we'll address that tomorrow morning. My name is Machteld Busz. I'm from the Netherlands. No one can pronounce my name, so I go by the name of Mac, which is a lot easier to remember. I work for an organization called Mainline. We're based in the Netherlands, and we are purely about harm reduction. We started working in harm reduction 30 years ago. And at the moment, we're working still in the Netherlands, doing outreach work, all sorts of interventions for people who use drugs. And we also work with a lot of partners across the world to implement harm reduction programs. Just very briefly, before I get into the topic that I want to address today, we have 3 objectives as an organization, and the most relevant for us is implementing services for people who use drugs. But in addition to that, we like to promote human rights for people who use drugs, and we like to talk about harm reduction as much as we can. So we try to promote harm reduction as a broad mindset, as a sort of a vision on how you can deal with drug use and people who use them. When we talk about harm reduction, I think what is important for us is to stress how broad you can apply harm reduction. So we like to use this definition that was really phrased nicely by our colleagues and friends at Harm Reduction International. And you see that harm reduction then refers to everything, basically, that reduces adverse health effects as a consequence of drug use, but also the social and economic consequences. And I find that quite relevant because, as you see here in the list of WHO interventions that we like to promote as well, this is a very health-oriented list of interventions that is there. Very useful, very important, of course, and I think here in South Africa, a lot of progress has been made in the past years to introduce these interventions. I also know that Drug Policy Week is a week where we like to set some new ambitions and goals. So the topic that I would like to discuss today is harm reduction in a broader sense, actually, than just the biomedical interventions that we like to use and that are promoted by the WHO, for example, but seeing into harm reduction for other groups as well, and seeing into harm reduction, for example, for people who don't inject, or people who might use something else than heroin. When you talk about harm reduction as a very broad package, you know, when you work in the field and you apply this in practice and you work daily in harm reduction, you know that harm reduction is far more than just biomedical interventions. But what is harm reduction about then? We asked that question in a meeting we did a couple of years ago and asked about 20 organizations across the world what harm reduction actually meant to them. And that led us to design a little bit as a gimmick, you know, some add-ons on the biomedical interventions that we promote in the field. A few things, you don't have to read them all, that people find important when they speak from the heart, when they speak about harm reduction, is, for example, nothing about us without us. Of course, we all know this term. Harm reduction as a very people-centered approach, much more than just offering services, very much about human dignity and human rights-based way of working. I'll go back to this later on. Today, like I said, I would like to discuss harm reduction for stimulant users because it's a group that is neglected a little bit. Now, we already struggle, of course, with putting harm reduction programs in place for people who inject. So it's ambitious maybe to also start talking about improving and promoting and expanding harm reduction for people who use stimulants. And also, we struggle as a field a bit with what works for these people. What can we actually offer people who use stimulants? If we don't have our set of needles to hand out, what do you actually do? So what is a harm reduction offer for people who use something else than stimulants and who might smoke, snort their drugs, or ingest it in, or put it in their body in some other way, some other creative way? So we worked on a research report the last year that was supported by the German government. And that report just came out last month. I brought some copies of the executive summary. And the idea was actually to really look into the evidence behind interventions that are there that fit people who use stimulants and their needs. So what we did is we described in this report, based on the literature, based on the evidence that is out there, what sort of interventions actually work, the evidence behind it, why it works. And in addition to that, we looked into 7 good practices across the world to start understanding better what we can offer to people who use stimulants. And when I talk about stimulants, by the way, you can think of crack cocaine, of crystal meth, TIC here locally, all sorts of new psychoactive substances that might stimulate you in some other way. The full report is available on our website, and I won't have time to go over all the interventions that were found to be effective, so I'll just briefly go over them, and I won't even describe them in detail. I'll skip through them a little bit, and then I'll go into the conclusions of the report, which are quite relevant in a discussion when you look into harm reduction and broadening that up. So, like I said, we looked into 12 interventions. We found evidence that they are effective, and they are the following 12. Safer smoking kits as an alternative for handing out needles and syringes is something that is actually very effective, also in terms of it being a point of contact with people, and that's something really nice as an outreach worker that you can offer to people. Safer smoking kits can consist, for example, of a clean mouthpiece or a pipe. Prevention of sexual risk and harm reduction for people in the chemsex scene, that's specific to the gay scene, where there's a lot of drug use in a sexual setting. There's a lot of programs that are found to be effective for these groups of people. And one of the advices in the report is to really integrate services for sexual health with harm reduction services, and especially also services that address mental health issues. Female-focused interventions are described in the report as very effective, addressing specific needs that women have. They need, for example, childcare very practically when they want to access services. So stuff like that is actually found to be very effective if you want to improve the health and societal position of women. Drug consumption rooms is something that is not so common outside of Europe. We have a few in Australia and in Canada, but actually it's an intervention that's described really well, and that's very effective in terms of giving people a safe space to use, them not being chased by the police constantly, and making sure that they can connect to services if they need to. In terms of overdose prevention, it's a very effective intervention. And then self-regulation is another one that works really well. I don't know if this is really boring if I just go over them, but I just want to give you an idea that there's so many other interventions around that we not always think of when we talk about harm reduction. Something in the Netherlands that is actually found to be really effective over the course of the years was housing first programs, for example. Now, if you look here on the streets in South Africa, obviously there's a huge issue with homelessness. Housing first programs, they address that first need. So basically what they do is provide people with a house, and it turns out that from that basis people actually start to take more control over their lives and even over their drug use. Substitution treatment for people who use stimulants is something that is very effective. It's a bit under-researched, but there's a lot of new experiments around using different kinds of substances to make sure that people get a more stable, basically, existence, as is the same effect in methadone programs. Substitution could also be formed, for example, by cannabis, to make sure that people relax a little bit, break their negative sleep cycle when they use stimulants. So that's also something that is really interesting in the field to look into and follow developments that are there now. Outreach and peer-based interventions are mentioned in the report. Drop-in centers, I just visited one here in South Africa yesterday, which gives people, again, sort of a safe space, a place to be away from the chaotic street life for a bit, and to regain their reflection, or they can reflect a little bit on what's going on and what's happening. Drug checking, very effective, as long as there's no serious regulation going on, people don't know what they're taking. So drug testing is actually an intervention that is very helpful. It doesn't work that well with people who have a street-based life, but for people who take drugs in the party scene, it's very effective. So at least they can test their drugs, know what they're taking, know what negative effects might be there. If you talk about adulterants like fentanyl here, I hear that it's popping up in South Africa as well. So the contamination of your drugs on the streets and the risk of overdose that goes alongside with that, you can prevent with drug checking, for example. So the report also looks into different internet-based interventions, therapeutic interventions. So I would encourage you to take a look. In addition, we focused on 7 case studies in this report, so we went more into depth in these interventions. One that is really interesting to talk about today is the case we described from South Africa. Here, a few years ago, 2 people that are probably in the room, Sean and Tara, were the first ones to design contemplation groups for people who use stimulants, amongst other things. And it's a very powerful tool to regain control over your drug use, to start regulating your drug use a bit more, and also to find support with one another. Some other cases that are relevant, for example, is the Indonesian case where people are doing now outreach work to address the huge increase of use of methamphetamines there. They are trying to find new ways to reach out to people who they can't find in the streets anymore. So they need to find creative ways to reach people in their homes or in small groups where they're using with. And see then what can you offer to people again. So what do you talk about? HIV might not be the most relevant topic to discuss for people who smoke meth. So how do you address, for example, issues around mental health like paranoia or depression, or being unproductive and not able to work? So there's some new developments in the world, across the world going on that's really relevant to look into as a harm reduction person. A few of the conclusions of the report, which I find very relevant to stress, is the very common polydrug use that people usually don't use just one drug. So if you use heroin, usually people like to combine it with a stimulant, for example. Here in South Africa, I think people are mixing quite a bit with crystal meth. So that speedball sort of cycle is something that we encounter in the field. It's something that we need to address when we do harm reduction work. And for example, if people here in South Africa, as an example, again, start on methadone, maybe the meth use is still there, and that's still a topic of conversation to have with a person. What we find is that social exclusion is something that many drug users encounter. There's a lot of violence, economic issues, unstable family situations that interventions need to address or to be able to address. And it's best to do that with very low threshold services. So creating a warm, safe, friendly, welcoming atmosphere to make sure that people feel welcome, have a place where they can be themselves, and start sharing what's going on in their life. What we found in interventions that were proven to be effective is that a sense of family and a sense of belonging is actually really relevant for people. Creating sort of an atmosphere of being accepted for who you are, not being judged, creating a sense of purpose again in someone's life other than just chasing after your drug. And to help empower people to increase self-care, again, regulation of their drug use if possible, so to promote control over their substance use. And there's many ways in which you can do that. Again, stable housing, finding work, very relevant if you want to get away from your street life. So effective interventions are found to address topics like that, and it relates back very well to the definition I gave in the beginning by Harm Reduction International, that there's also a lot of social and economic consequences that you can encounter when you use drugs. And projects that focus on stable housing and fixed jobs can sort of break that cycle of the street life. Meaningfully involve peers, very effective, it's proven. Same for providing factual, non-sensational information about drug use, about the risk of use. Offering concrete benefits is found to be effective as a way to reach out to people, make contact. So you can think again of smoking kits, for example, as a way to engage also in contact and make sure that people know about the risks for contracting hepatitis C, for example, by sharing their pipe. better integration and linkages between services that might be out there, mental health services, sexual health services, and mental health issues, and addressing those is quite specific for people who use stimulants, I would say. Now, why this long list? I think what is relevant if you see all this is that a lot of these interventions are not specific for the substance that people are using. They relate to the lifestyle that people have and that they have to survive under. So the evidence that we saw in the report links very much into the model that, or the add-ons that I showed you earlier, where people spoke from the heart and said, this, I think, is what harm reduction is about. The evidence actually supports those claims, which is really interesting to me. So the collective sort of, memory that we have as a harm reduction field, where we know, by heart what is effective, what works, that's exactly what the evidence is now showing in our report. So involving peers, harm reduction is so much more than offering services. It's about human dignity. It's about restoring that human dignity. It's about understanding drug use in a social context, in a context where policy has an important role to play, where you can actually, by creating more positive policies, creating a better space for people to live in, and giving them chances to get out of a chaotic street life. Human rights-based approach, holistic approach. So all those things we see back in the evidence that we now found in this report as well. So speaking a bit, the theme of the week is policy to practice, but speaking from practice to policy, I think what this report shows, but mostly what the field also shows, we know what works. And the only thing that we want to know is, when are we going to do it and implement it in a broader way? When are we going to free up those resources to actually do what we know that is effective, so that we can actually make a change in people's lives? That's what I wanted to talk about. Again, the copy of the executive summary is here. Look up the report at our website. I think it's an interesting contribution to what is out there now. We also brought a magazine, our mainline magazine that we always publish, and it's about uppers, stimulants. So if you're interested in that topic, feel free to take a copy. And you can catch me whenever I'm around for tomorrow and today. Thank you very much.